The last talk in this interesting session, together with the ESC, will be given by Dr. Michel Comaja. He is the immediate past president, and it will be Cardiology in the 21st Century, Challenges and Opportunities. A very interesting topic.
Dear Professor Lotan, Professor Varas, distinguished co-chairpersons, ladies and gentlemen, I would like first to express my gratitude to the Israel Heart Society for inviting me. It's always a pleasure to meet our friends from Israel and to exchange on a very high level about cardiovascular science. Cardiovascular diseases remain the #1 cause of mortality and morbidity, both in the so-called developed countries, but also in emerging countries. And to illustrate this fact, I would like to show you European data. This pie chart shows you the cause of mortality in patients of male gender under the age of 75 years, and the red part represents the cardiovascular deaths, which is approximately 40% in men, and the situation is very similar in women. So it's a #1 cause of cardiovascular mortality in Europe and probably in the rest of the world. The first question we should ask ourselves is, have we made progress in this matter? And I think that cardiologists can be proud of what has been achieved over the last 20 years. This slide shows you the annual mortality rate due to ischemic heart disease on the left-hand panel and of stroke, the mortality rate on the right-hand panel in OECD countries. And you can see that there is obviously a temporal trend for a significant reduction in these rates, although there are some exceptions. And another example of this success in ischemic heart disease is taken from a survey which was presented at the last annual meeting of the ESC, which is called the FAST-MI registry, which was conducted in my own country. FAST-MI was a survey of the mortality rate after an acute myocardial infarction during 4 periods of time, ranging from 1995 to 2010. And the outcome is absolutely impressive. 15 years ago, the non-adjusted mortality rate in the 30 days following hospitalization for an acute coronary syndrome was in the range of 14%. And you can see that it has gone down to around 4%. So it's really impressive to see how much we have progressed in the management of acute coronary syndrome. And of course, this is the result of the wide dissemination of reperfusion therapy, be it by PCI or by thrombolysis. You can see that in 1995, the early or rescue PCI was concerned only 10% of the patients, and 2 years ago, it was the majority of the patients who underwent, in my country, an urgent PCI. So obviously we can be proud of this achievement. Another example of the success of cardiology comes from heart failure. This is a recent European survey in 8 different European countries, and it shows once again on the left-hand panel the mortality rate in heart failure in these various countries. And you can see that there is obviously a decline, which I think can be attributable to the wide dissemination of ACE inhibitors, beta blockers, and other life-saving drugs. However, there are matters of concern. One is the rise of obesity in the world, which is a global epidemic, and some areas are more touched than other ones, and in particular, obesity in children. The second matter of concern is the epidemic of diabetes, which strikes the whole world. You can see here the prospect for 2025, and it is indeed scary, and here again, particularly during childhood. And this probably will counterbalance what we have achieved so far due to the management of cardiovascular disorders, not to speak of the rise in smoking in the adolescents, be either women or men. And as a result, despite all the efforts which have been made, the prospects are gloomy. And these are US data which show that in 20 years from now, approximately, there should be a rise of 10% in the rate of cardiovascular diseases at large, and particularly of heart failure, 25%, and stroke, 25%, not to forget ischemic heart disease, approximately 16%. And as a result, the prospect regarding the cost of the management of cardiovascular disease show that there will be a very huge rise in the cost generated by these diseases, whether it is direct cost or indirect cost, including sick leave. So we are facing a challenge. Let's go back to the old continent. And what is the context? In Europe, we are facing an heterogeneity of risk, but also an heterogeneity of access to or of affordability of the different procedures. This is a map which shows you the annual mortality rate in male subjects for chronic ischemic heart disease, and you can see that there is a gradient from south and west to east and north. And this is true not only in men, but also in female patients. And actually, the ESC has acknowledged these disparities in its scorecard, which is the cardiovascular risk assessment card, and we identify, on the one hand, low-risk countries, such as France, Greece, Italy, Portugal, more or less southern countries, and the rest of Europe, which is at higher risk of cardiovascular disease. What are the explanations for these disparities? One explanation is the diversity of a healthy life. And just to take an example, this slide shows you the rate of smoking in a number of countries, and not to enter into details, you can see that there is a huge heterogeneity, and that in particular Eastern countries in Europe, you tend to have a very high rate of smoking. And as a result, when we look at the trends, in many countries there has been a decline in the rate of ischemic heart disease, but not in all, and you can see on the top 5, which are the countries where the rate has increased, not surprisingly, they are all Eastern countries. So we should do something about smoking ban in these countries. The second explanation is, of course, economic. This slide shows you the total health expenditures in various countries, and in deep blue you have the public health expenditures, in light blue the private health expenditures. And you can see that there is a huge heterogeneity across ESC countries. And this is illustrated by the fact that if you look at the rate of coronary angioplasty per 100,000 inhabitants, there is a very huge diversity across countries. And another example is, of course, procedures regarding ICD implantation, where here again there is a huge diversity, which is partly driven by economic considerations. And finally, the system is not stable but evolving. And actually, the healthcare system's affordability is changing rapidly nowadays. First of all, because cost containment policies are put in place everywhere in Europe, and of course, they affect the willingness to pay from governments or social security systems. Secondly, you know that there is a huge economic crisis affecting the whole of Europe, which also has a big impact on healthcare budget. And finally, there is a global trend for a reduction in total coverage and a trend to increase the part of the cost which is paid by patients, that is co-payment rates, which may be a limitation to the access to procedures or expensive medications. The other context which I would like to outline is that we have in Europe, and I think this applies to most of the Western-style countries, substantially invested in sophisticated devices or procedures, and that in parallel we can observe a lack of implementation of very simple and cheap prevention measures, although non-communicable chronic diseases are expanding rapidly. And to illustrate this statement, I would like to show you the number of PCI procedures in 1992 in ESC countries was less than 200,000 per year, and in 2008 was over 1 million. So obviously we have heavily invested in cath labs or electrophysiological stations. And on the contrary, when we look at what we have been able to do in prevention, I would like to take the example of the EuroSPA studies. There were 3 studies of EuroSPA which were performed over the last 12 years. And the results are striking. The last one is shown by the green bars. And you can see that in 12 years, there was no progress in a high cardiovascular risk population. In the smoking rate, there was an increase in the obesity rate and in central obesity. The number of patients with controlled hypertension did not improve. The number of diabetic patients has risen, and the only beneficial effect that we can claim is a reduction in total cholesterol or in LDL cholesterol, and also a rise in life-saving medications, including antiplatelet agents, beta blockers, or ACE inhibitors, or statins. If we look in the EuroSPA studies to the patients who were evidently coronary patients, here again there is progress to make. In particular, this slide shows you the attendance to a cardio rehabilitation program after an acute myocardial infarction. And you can see that, one, there is a huge diversity across countries, although this is a cheap method which has demonstrated to improve outcomes in coronary patients. And secondly, the average rate of cardio rehabilitation programs is only 1 patient in 3 in this survey. And in these coronary patients, if you look at individual risk factors, a similar pattern can be found. No progress in the rate of smoking, an increase in obese patients, no progress in blood pressure control, increase in diabetic patients. So we have a lot to do in terms of prevention in a very high-risk population. And finally, if we look at the EuroSPA primary care patients, it is striking to see that only 17% overall of these patients benefited of a program of education for a better lifestyle and risk factor management. Why is the situation so? The first explanation is that there are different stakeholders which have different perspectives. In hospitals, cardiologists are encouraged to perform expensive procedures because in most countries it's a fee-for-service system which has been put in place. The social security system have a different perspective because they are taking care of the global population. Secondly, you may have different interests in private and in public systems. The second explanation is that cardiologists and more generally physicians have a lack of awareness or a lack of interest for health economists, and we don't really care at the moment on the cost effectiveness, which is key for the future given the constraints which are related to the economic situation. And the third explanation is the fact that we have generated chronic diseases in cardiology, and in many instances there is a lack of proper collaboration between professionals, that is general practitioners, dietitians, nurses, rehabilitation doctors, and cardiologists. And this is very unfortunate. And I would like to show you an example of where the collaboration between cardiologists, GPs, and nurses has been beneficial. It is the EuroAction study. In red, you have the interventional arm, which is intervention of nurses together with doctors. In blue, the standard of care. And you can see that both in hospitals and in general practice, the implication of nurses resulted in a significant improvement in the number of patients reaching European targets for a healthy diet. And there was also a similar trend for a better control of blood pressure. So obviously, we should try to coordinate more our activities with other professionals in cardiology. Finally, are there solutions? I think there are. One is to invest in prevention, and the European Society of Cardiology, together with national cardiac societies, should coordinate their efforts to lobby at the European Union level or at the national government levels in order to invest in public campaigns for prevention. Secondly, given the burden of chronic non-communicable disease, it is obvious that cardiologists alone cannot cope with all of this, and that they should cooperate with sister societies such as diabetologists for the management of these chronic diseases. We should also try to create better alliances with other professionals, including GPs and nurses, particularly in light of the declining demography of doctors. And finally, we should try to homogenize at the ESC level education in cardiology in order to be better prepared to the changes which are occurring. And education will be a key factor to try to be successful in the adaptation. And I have to say that the ESC has been investing heavily in modern ways of education in order to try to homogenize cardiovascular medicine education across its countries. And we should certainly target the young generation of cardiologists, because the way the young generation is learning is different from what we have been experiencing when we were students. They are all electronic, and they tend to be attracted by distance learning activities, and this is why the cardiologist of tomorrow should be targeted for our tools. Guidelines is of course one tool because it is based on evidence, but we should go from paper guidelines to electronic versions of guidelines available on smartphones or whatever for this junior generation. And I would like to mention here a survey that we did 3 years ago, which was asking to a panel of cardiologists, including junior one, this is the purple, these are the purple bars, what is your preferred format to receive guidelines information? And you can see that in the young generation, it was the web, so electronic, in more than 75% of cases. So scientific societies, such as the ESC, should take this in consideration. Another tool that we have been developing is the ESC e-learning platform, because the future will be the self-assessment of our skills, both in general cardiology and in subspecialty, and this will progressively replace classical learning sessions, and we have developed this tool, which is of course available to all our members. A third tool is to evaluate what we are doing in real practice, and that is registries. It is crucial for the future that the profession examines how it treats in real-life situation the various cardiovascular diseases, and the Europe Observational Research Programme developed by ESC is a typical example of what we should do in order to take lessons if there are gaps between what is observed and what is recommended. And I think that this way of changing our education modes and adapting to the new modalities of distance learning is probably the best way to adapt the profession to a very fastly changing environment, which includes the expanding gap between what can be done and what can be afforded in healthcare, the fact that the society is aging in general and that there is an explosion of chronic cardiovascular disease, the increasing accountability of all institutions, the fact that we are no more considered like respected experts and we are facing partners, that is, sophisticated consumers who are our patients, and of course the rise of ethical issues. Finally, we will need to adapt the profession to new ways of managing cardiovascular patients. This includes the development of so-called personalized medicine. One size does not fit all, and we will need to develop biomarkers and other techniques in order to individualize the management, in particular, of chronic cardiovascular disorders. Probably telemonitoring will be one of the solutions to take care of the burden of the rise in chronic non-communicable disease, not to speak of innovative therapies going from stem cells to novel biomarkers or devices. I think that the ESC, due to its global reach, is one of the major cardiovascular institutions which is able to tackle this challenging issue of the management of cardiovascular disorders in the future. And I think that we should never forget that we as ESC, together with the national cardiac societies, are in the end the only voice of patients who are affected by cardiovascular disorders, because even governments tend to reduce their support to healthcare system, and indeed we are the only protection of patients with this respect. Before concluding, and since we are in a very special period of time, because there was a celebration of the 65th anniversary of Israel last week, and today we are celebrating the 60th anniversary of the Israel Heart Society, I would like to wish a bright future both to your nation and to the cardiovascular community. And it is always a pleasure to come and discuss with my friend from Israel. Shalom.